We all have these mental quirks. For example, I always see the word coworker as cow orker, though I have no idea what orking a cow might be. Maybe it's like turning an elf into an orc, only you're doing it to a cow. The other word I have issues with is Super Bowl, which I now see as Superb Owl. And today is Superb Owl Sunday. I need to get this podcast done so I can not watch the Super Bowl. I'm sure it will be on in the background, but I'll barely pay attention, even though Seattle is as close as Portland will ever have to an NFL team. But then I'm from Portland. I have to hate Seattle and Los Angeles on general principles. Anyway, this is the Puscast. It is covering the last 2 weeks of January 2014. The references are available on the website, edgydoc.com, where you can find links to my growing multimedia empire. You know, the usual shtick, podcasts and blogs and apps and unicorn horns. So let's move on to the literature, shall we? I will just note that in the never-ending quest of producing a superior sleeping agent, the IDSA has produced its clinical practice guideline for vaccinations of the immunocompromised host. Guidelines are always great, and guidelines are always boring, often like reading the phone book. But for those of you who take care of the immunocompetent and want to know how to vaccinate them, you can find the guidelines at idsa.org. I always thought Mercutio said a pox on both your houses, but in looking up the reference, it is a plague o' both your houses. Zounds, a dog, a rat, a mouse, a cat, to scratch a man to death. But this is about pox. Interesting two things about the pox virus. One of the results of the extinction of smallpox, or at least near extinction of smallpox, is that monkeypox is coming back. As I mentioned before, you don't get monkeypox from monkeys. You get monkeypox from rodents. It was first discovered in monkeys. This was a study that looked at genomic variability in monkeypox viruses, and is a lot of variation in monkeypox. I mention this because they say, quote, the potential for accelerated adaptation to humans should be monitored through improved surveillance. So part of the worry, of course, is that monkeypox could jump into humans and act more like smallpox. I said earlier that smallpox is almost gone. I know it exists in a couple of labs in the United States and I believe the Soviet Union, and we've had no active smallpox for 30 years. But this was a fascinating article from the CDC that looked at smallpox found in historical specimens. For example, they can find it in mummies, in archaeologic excavations, in permafrost. They have found bodies in the U.S. that look like they died of smallpox. And there are pathologic specimens that have variola DNA in them. People could potentially and accidentally run across some smallpox in a corpse, and for all we know, it could be viable. And if it is viable, start up smallpox again. The finding of variola in historical and archaeologic specimens and its potential infectivity is predominantly a theoretical risk, but an interesting one nonetheless. Sounds like it would make a good plot for a movie or a thriller. The other organism that evidently is having a lot of genetic variability is the West Nile virus. There was an outbreak in Maricopa County, Arizona, and they found that there were 3 distinct genetic variants wandering through the population of Arizona at the same time. The significance of this may well be that as it varies in its antigenicity, that population immunity will wane and there can be introduction and reintroduction of new strains of West Nile into populations and lead to future outbreaks. I still keep waiting for West Nile to come to Oregon. We have not had hardly any locally acquired cases. I personally think it's the great beer that keeps it away. Statins, of course, are immunomodulatory drugs, and unfortunately or fortunately, to date they haven't panned out as a way of treating infections. There's been a contradictory literature to suggest that statin use decreases mortality when patients are admitted, though that, of course, could be a marker for better health care. Interestingly, there was an article that looked at the risk of developing herpes zoster, aka shingles, in patients who are on statins. And they found that if you were on statins, you had a small but real risk of getting zoster compared to those who were not on statins. The risk if you are on a statin is 13.25 per thousand patient years versus 11.71 per thousand patient years if you were not on statins. Kind of makes you wonder, since zoster is also an increased risk of stroke, if by getting your increased risk of zoster on statins, you then decrease your risk of stroke because you're on, well, a statin. Medicine's too damn complicated. But the general rule of thumb remains, no good deed ever goes unpunished. One of those diseases that you may not think about but should keep an eye out for is dengue. This is a report of hemophagocytic lymphohistiocytosis in a patient who had dengue, but the important thing is that it was locally acquired. This was a United States acquired dengue, and it was the third in the United States in the last decade, and they were all associated with travel to Texas. It's coming north. And dengue is also in the Florida Keys, so I'm looking forward to it and West Nile to eventually come to the Great Pacific Northwest. I wonder if beer will prevent dengue like it does West Nile. I remember being told years ago that in an HIV patient who is not being controlled with HAART and is having active viral replication, that because it is such a sloppy replicator, not unlike humans, it undergoes a mutation at every point in its DNA 3 times in a 24-hour period. That's pretty remarkable. Like many things I learned years ago in my fellowship, it's in my brain, but I do not have a reference. However, this was a study that looked at HIV resistance to the integrase inhibitors in patients and found that 1 in 6 patients had resistance to integrase inhibitors such as dolutegravir and raltegravir. The other interesting article in reference to HIV from my perspective this month was a study where they looked at the etiology of mediastinal lymphadenopathy in HIV patients. This is done during the HAART era. And they looked at 217 consecutive CAT scans in HIV patients and found that a third, 33%, had a malignancy as the cause of their mediastinal lymphadenopathy. If you had consolidation on your CT as well, you were less likely to have a malignancy. And if you had big, juicy nodes, you were more likely to have a malignancy. And this was independent of CD4 count. So if you find lymphadenopathy on an HIV patient, you should go after it looking for cancer. HPV is quite common in men who have sex with men. In a cohort with a mean age of 21 years old, they found 70% had some sort of HPV infection, and that 37% had HPV 16 and or 18. They comment that perhaps one way to decrease the incidence of HPV in men who have sex with men is to vaccinate all male children as well. Yeah, like that's going to go over well. We can't get hepatitis B vaccinations or HPV in heterosexuals. I can see a real significant chunk of the population who would not be thrilled with the message, yes, vaccinate your boy, he may be having anal receptive intercourse. But it does highlight the need to be wary of HPV in men who have sex with men and to look for cancer in that population. HPV-related cancers, however, are increasing across the board as is. Now that the pulmonologists, when they do bronchs, can do molecular testing for all sorts of viruses, We're seeing more and more viruses in adults that I had never diagnosed before. This study looked at 2,225 patients over age 50, where they did a ton of viral testing for their respiratory infections, and they found that 17% had flu, but interestingly, 10% had rhinovirus, 8% had RSV, and 7% had metapneumovirus. This study concerned RSV as an etiology of respiratory infections in adults, and it tends to be a lot milder than influenza, but does occur in patients over age 50. One of the depressing things is that I'm now in the risk group for all sorts of infections as I've gotten older. I used to be in the no risk group, now I'm in the increasing risk group. Getting old sucks. This has been the second worst flu season of my professional career, the worst being when H1N1 hit. And fortunately, it is now declining. I'm talking, of course, about the flu, not my career. Hopefully, I'm still somewhat compos mentis. Several studies have pointed to the importance of schools as a source for multiplying influenza outbreak. This study out of France looked at the data of 25 epidemics of flu-like illness and discovered that there was a correlation between the volume of commuting and the spread of disease. Should be no surprise, as when people move about, they take their infections with them. Commuting routes are a lot like migration routes, and they bring infections with them. Of course, the best way to prevent flu, perhaps, is to get the vaccine. I say perhaps because probably the best way is to lock yourself in your room and never leave, since that's not practical for most people, and inhaling is an important part of life. The flu vaccine is your best bet. Unfortunately, it is not a great vaccine, and this study looked at vaccine effectiveness in the 2011-12 season, which was a quiet flu year. They found that for the A component, the vaccine effectiveness was about 65%, but for H1N1, but only about 40% for H3N2. And that for the B component of the vaccine, efficacy was about 58%. So for simplicity's sake, I always tell people that your chance of getting the flu is halved by getting the vaccine. It kind of depends, of course, on what's circulating, etc. Curiously, in this study, and this has been seen in other studies as well, prior vaccination decreased the effectiveness of the flu vaccine that season. Why that is and whether or not it is a real phenomenon is up in the air. There are some studies to show that you have an attenuated response to repeated vaccinations, but this is not a consistent finding in the studies. Whether or not prior vaccination decreases the effectiveness of the vaccine is yet to be really determined. Similarly, there have been a couple of studies to suggest that prior exposure to H1N1 might make subsequent disease worse. That, too, has yet to be fully elucidated. But the flu and flu vaccine is not as straightforward as one would like. Tetanus is so much easier. The two bands I think that have the greatest names are 10,000 Maniacs, which I've always liked, and Smashing Pumpkins, which I think is a great band name. I still find the song, Despite All My Rage, I'm Still Just a Rat in a Cage, kind of some teenage angstiness that seems a little pretentious to me, but I still like the song. But every time I read about rats, I always think about that song. This looked at LCM in those who are in a feeder rodent operation. You have to generate large amounts of mice and rats, both for labs and for feeding other animals that eat rats. They had an outbreak of lymphochoriomeningitis in the facility. They had 32% of their employees were seropositive and 4 had aseptic meningitis. And they found that about 1 in 5 of their mice had LCM, probably brought in by wild-type mice. But always bear in mind LCM in people that have mice exposures. I still have not diagnosed a case in my career. Infections can cause long-term sequelae. I often think of it like a rock in the pond. The rock is the infection, and the ripples are the post-infectious problems. The rock comes and goes, but the ripples can remain. I have been impressed over the years of the number of people that get an acute infection and then end up with a post-infectious chronic fatigue state. I think this is a real subset of chronic fatigue syndrome, and this is somewhat supported by the literature that shows a variety of infections can cause a post-infectious disease state. There is a post-Lyme symptoms. This is different than chronic Lyme disease, which does not exist. But there are people who, after getting Lyme, have persisting symptoms, headache, fatigue, etc., and you can find no evidence of ongoing Lyme disease in them, yet they had an acute infection and they remain sick. This study looked at post-Lyme symptoms in patients with no evidence of an active Borrelia infection and found that there was an immunologic difference in those who had post-Lyme symptoms. They tended to have high interleukin-23 levels. And since my knowledge of immunology stinks on ice, I will just quote from the conclusion. High Th17-associated immune responses, often accompanied by autoantibodies, correlated with post-Lyme symptoms. And it would appear that patients with post-Lyme symptoms have an immune dysregulation induced by the spirochete Borrelia. This, by the way, was a study done in Europe where they have different strains of Borrelia that cause Lyme disease. It will be interesting to see if similar anomalies are found in other patients with post-infectious fatigue states. Personally, I bet someday we will find that a subset of these patients do have some sort of ongoing immune dysregulation to account for their symptoms. There are diseases I just don't think about, probably because they're named after metal bands. But there were 2 reports of anthrax in emerging infectious diseases this month. One was a case of inhalational anthrax, and they never did figure out where he got it from. He traveled around 4 states where there is a lot of anthrax, and that being North Dakota, Montana, Wyoming, and South Dakota, but they never figured out where he got his anthrax, though it sounds like he was quite the rural adventurer, being around loose rocks and elk antlers and the like. The other is to note that Georgia is apparently hyper-endemic with cutaneous anthrax patients. This is not the Georgia of the American South, but the Georgia of the old Soviet Union, where rates are now those of Turkey, another hyper-endemic country with anthrax. And it is a real toss-up as to what would be worse, a thrash metal band or a painful cutaneous infection with local necrosis. I think I'd take the thrash metal band. It is important to remember that anthrax has been spread by contaminated animal products that have hides or meat or hair, the classic one being bongo drums. So if you get a set of bongo drums from the old Soviet Georgia, be careful. I always think of bubonic plague hitting Europe for the first time in the Middle Ages. However, there was the plague of Justinian from 541 to 543 AD. So they found 2 people who died then, and they took out their teeth. And often you can find DNA in the pulp of teeth. And they went and they did indeed find Yersinia pestis in both of these teeth. They then compared the genome of that Yersinia to all the other known Yersinia, including the plague of the Middle Ages, and found this to be a different Yersinia pestis that had been hitherto unknown. Whether this is still a reservoir of this particular Yersinia in rodent populations or it has died out is unknown. But plague hit Europe twice then, first in 541 with the plague of Justinian, and then with a different strain 800 years later in medieval Europe with the Great Black Death. Great as in large in numbers, not great as, oh, isn't that fabulous. Although the Black Death was one of the few times that CO2 accumulation in the atmosphere not only slowed but declined over the lifetime of the human race. That's what we need to cure global warming. It's just a massive die-off of humans. I'm not going to volunteer. You? Years ago, maybe 15, we did a survey at my hospital to see what people were using for uncomplicated urinary tract infections in women in their childbearing years, and found that no two patients got the same antibiotic prescription. That's the kind of thing that just drives me nuts. This study showed a similar lack of knowledge base for the treatment of uncomplicated cellulitis, which, if you don't have boils, is due to Group A strep, or Group A strep, and to a lesser extent, Group G strep and Staph aureus and Staph lugdunensis, all of which are treatable by cephalexin or dicloxacillin. So they looked at the use of antibiotics in uncomplicated skin infections and found people were doing an awful job at least half the time. They found that patients got gram-negative coverage 4% of the time, don't need it. Combination therapy 12% of the time, don't need it. Treatment for 10 days or more in 42%. 10 days is more than sufficient. Most patients with cellulitis need 5 to 7 days of Keflex, cephalexin, or dicloxacillin, or probably just amoxicillin, since most of these are Group A strep. It always boggles my mind how often simple, well-described clinical problems are badly treated. And they do similar things with preserved specimens besides get smallpox or figure out if people died of plague. I should say no one's gotten smallpox yet from a specimen. But they had this bowel from someone who died in the 1849 Vibrio cholera outbreak of Philadelphia. It was just sitting in a jar. So they took it out and they looked for Vibrio DNA, and they found it, and they typed it, and they found that it was an O1 biotype that was similar to the O395 strain that caused the second pandemic of Vibrio cholera. I'm just fascinated by how they use these preserved specimens to sort out the cause of ancient epidemics. Well, 1849 is not that ancient, but the Justinian plague of 541 is kind of old. Regular listeners to this Puscast, and like Mr. T, I pity the poor fool who does that, know my bee in the bonnet about infections leading to thromboembolism of one type or another. Infections are inflammatory. Inflammation's prothrombotic, and prothrombosis leads to thrombus. Here is yet another article, this one out of Clinical Infectious Diseases, that shows that patients who have active tuberculosis have an increased risk of venous thromboembolism. The incidence was 2%, and it occurred more often in African Americans. Amongst my many predictions for the future, besides that of urine transplants for repeat UTIs, is going to be that everybody with an infectious disease goes home on some sort of anti-clot drug. Alls we lack currently are the studies to show efficacy. There are two types of consultations that make me nervous: OB service and ophthalmology. So I don't think I see these very often, but this is a study that looked at the efficacy of long-term TMP sulfa in patients with toxoplasma retinochoroiditis. I thought it was chorioretinitis, but this says it's retinochoroiditis, which is much harder to say, come to think of it. So they compared patients who received 45 days of standard therapy and then were either randomized to receive placebo or TMP sulfa for a year. 13% of patients developed a relapse, or I should say a recurrence, in their eye, as opposed to 0 in those who are on the therapy for a year. So it looks like the treatment of toxoplasmoretinitis, or in this case retinochoroiditis, is going to be long-term TMP sulfa. I swear to God, people like to come up with names that make it harder for the non-specialist to pronounce or even spell. I still can't figure out where the P goes in ophthalmology or the R and the H in Crohn's disease. Too confusing for me. Beware the compounding pharmacy. There were the outbreaks of steroids that were injected causing meningitis earlier in the year. Now there's some cases where patients developed fusarium in their eyeball or bipolaris hawaiianensis in their eyeball after being exposed to compounded triamcinolone that was used for intravitreal injection. There is definitely an issue with compounding pharmacies and products that are going to be injected into you. I probably wouldn't worry about a pill or a salve, but I wouldn't take an injection from a compounding pharmacy. And that brings us to a close. I'm going to go for a walk and watch the superb owl. This has been the Puscast, covering the last 2 weeks of January 2014. The references are available on the website, edgydoc.com, and if I remember, it should be in the lyrics of the song. Just go to lyrics and you should see all the references. I keep forgetting to do that. Otherwise, you can participate in my growing multimedia empire at edgydoc.com, where you will find links to all my websites, my podcasts, my books, etc. But more importantly, go check out the Society for Science-Based Medicine, a new organization that started January 1st of this year, of which, for good or ill, I am the president. It is an organization devoted to, obviously, science-based medicine. As is often the case, what you are for is often defined by what you are against. And this is an organization that is devoted to combating pseudomedicine in all its forms, acupuncture, chiropractic, etc., etc. So go to sfsbm.org and check it out. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye.